Hi, my name is Kirk, your host of the Staying Healthy Today Show. Today's show topic is the treatment of Alzheimer's disease and cognitive decline using precision medicine. Where are we now? Where have we come from? And where are we going? Our guest today, I'm honored to have Dr. Dale Bredesen. He's a neurologist. He did his medical training at Duke University. He was a chief resident in neurology at the University of California, San Francisco. He worked in the laboratory under Nobel laureate Stanley Krusner and was a NIH postdoctoral fellow there. He has held faculty positions at UCSF, UCLA, University of California, San Diego. At one time, he directed the program on aging at the Burnham Institute in La Jolla, California. And in 1998, he was the founding president and CEO of the Buck Institute. And now he is working in conjunction with many things, but he is working at the Precision Brain Health Program in Santa Monica, California. So welcome. Thank you for taking the time out of your busy day to come on the show today.
Thanks so much, Kirk. Thanks for having me.
So I wanted to start off with something that got me originally, and it's in your first book, but 36 holes in the roof. I have an analogy I give patients. I tell them your health is like spokes on a wheel. You may have 15 loose spokes, and I might help you tighten 7. But what happens is if the wheel starts to turn, sometimes 3 or 4 more tighten without any effort. And I remember you telling me or telling us, that there was 36 holes in the roof, and I don't know how many there are now. But if you filled some of those, then sometimes the process would continue. You need to fill more holes. So can you tell us about the 36 hole analogy and where we are now? Do we have 56 holes or what would you think?
Yeah, so what happened was we were looking at all the things that drive cognitive decline. We spent 30 years in the lab with experiments with cells and with transgenic mice and fruit flies and all this sort of stuff, looking at what are the things that actually drive the loss that we associate ultimately with Alzheimer's disease. And we looked at, where APP is cleaved and what ApoE4 is doing and what the signal transduction was and what happens with phosphorylation of tau and all these molecular interactions. So I started listing them and, we got to 36. We thought, okay, there are 36 different things. And at the time, we were thinking of it quite differently than we are now. At the time, we thought, okay, so you got to get all these things lined up, all your ducks in a row, because if you've got things that you got holes in your roof, the rain is going to come through. So we want to do all these things. What we've realized is just in the last couple of years is the next iteration of that, which is that, and really kind of exciting when I first saw this. There literally is a systems biology mode, just like you would go from sleep to wakefulness. And when you go from sleep to wakefulness, hormones change and your vagal nerve tone changes and all these things change. When you go from your EEG changes, all that changes as you go from sleep to wakefulness. Sleep is really good for certain things like repair and like memory, laying down memory. A wakefulness is really good for other things. So we have these mode switches and we see the exact same thing with these 36 holes. So there is a whole mode which is about connectivity. And when you're making connections and keeping connections, your APP, the amyloid precursor protein, is cleaved at a single site to give you SAPP alpha and alpha C-terminal fragment, alpha CTF. And these things go off and it's literally signal outside the cell and inside the cell. You're going to make and keep synapses. Your ApoE4 is off your DNA. It's a transcriptional repressor, as it turns out. And so it is literally cycling on and off. And when you're in that connection mode, it's off. And your ApoE4 is acting differently. Your tau is unphosphorylated and is supporting neurite outgrowth. You have a higher rest and higher renin and lower NF-kappa B. So the bottom line is there's dozens and dozens of things that all line up as a mode. You're literally in this mode of connectivity. When you have exposure to insults, to pathogens, changes in your oral microbiome, chronic sinusitis, tick-borne illness, metabolic syndrome, mycotoxin exposure, go on and on and on. These things literally will signal to your brain, you must now move over to protection mode. So you go from connection mode to protection mode. Every one of these things is changed. You change the way you cleave your APP. Now you cleave it at 3 sites. And by the way, you now make amyloid out of the A beta fragment is one of the things that comes from those 3 cleavage events. The C-terminal fragment that we had studied years ago, so-called C31, comes from that. The SAPP beta instead of SAPP alpha. Your ApoE4 is back on your DNA, and it is inhibiting things that would otherwise turn down inflammation. So again, you can go through all these things, and you're literally resetting the way your brain reacts, and you're now in this protection mode. Now, if you stay in that mode for years, we call that Alzheimer's disease, because you're going to now keep making this amyloid. That is, it turns out to be an antimicrobial peptide. And by the way, the phosphorylation of tau changes it from something that stabilizes microtubules to now it is an antimicrobial protein. It changes the charge, of course, when you phosphorylate it. It pops off the microtubules. It is now going around and killing organisms. So you really have this remarkable mode switch. And that's why we saw these 36 holes in the roof, all these things that are changing as you go into that mode. So what we want to do, first of all, we want to know if you're in that mode already, because we want to now get you back to the connection mode and out of the protection mode. We want to get rid of the things that you're having to protect yourself from. We want to get rid of that amyloid and phospho-tau. We want to go right back, but we want to get rid of the things that are causing that, and then give you that resetting into the connection mode. And that's where we see the best outcomes.
So that's 36 holes. I think I was thinking differently. The 36 holes are actually the steps to take us into a protective situation. Correct. I mean, they're the biological switches. I was thinking there are 36 holes, and you take and you plug in a nutrient, or you plug in a hormone, or you plug in something like that.
And essentially it translates to that. So for each of the good news is for each of these things, there is a way to address them. So, if you are having problems from a specific pathogen, and a great example, the herpes family turns out to be intimately related to this signaling of the nervous system. So it is a definite family that is closely related and important in Alzheimer's disease. And you see that with herpes simplex type 1, to a lesser extent with HSV2. You see it with HHV6A. You see it with cytomegalovirus, Epstein-Barr virus, varicella-zoster virus. All these herpes family members are turning out to be quite important in this protection mode. So, what you say is true. You're still going after that, but you're right. The way I originally was looking at this was, what are all these things that are changing, and do we have to address them all? And as you can see, as long as you have a bunch of leaky holes, you're going to have issues. And it comes back to what you said, though. As you start to address these, the great news is ultimately you have that mode switch back to connection mode, and those last few holes snap shut on their own. It's really striking.
So just the initial question was, are there more switches that you've discovered, or more holes to plug?
Yeah, we know of a few. Yeah, we know of a few more now. As I've always said, they're not thousands. It's dozens. We know of about 45 now. So there are things we didn't know about back then. We didn't really know back then about REST, which came out later, which is a trophic support factor. We didn't know as much about renin as we do now. So there are several things that are critical that we didn't know about. We didn't know, we were actually studying the hippo signaling pathway in the lab, but we didn't know that how it related to all of this. And now we understand that better. So we're understanding more and more about how these things work. And the nice thing is we're seeing how they can be adapted to other diseases. As an example, as you know, Ted Turner just passed away, of course, the founder of CNN. And Ted, unfortunately, had Lewy body dementia. And it turns out if you look at the parallels here, you just go down and write down again. Actually, I just wrote something up on this, which I'm happy to send you. that shows the absolutely remarkable parallels. So instead of having amyloid and tau, you have alpha-synuclein. But these things still are coming. You're still switching over from a connection mode to a protection mode. Instead of it responding to specific pathogens, it actually responds. The synuclein is one of the things that responds to some DNA damage. But again, same idea. Whereas the amyloid tends to be quite good at killing herpes family viruses, as I just mentioned. The synuclein is actually better at killing RNA viruses instead of the DNA viruses, and specifically things like West Nile virus. So we're coming to see all of these neurodegenerative conditions, whether you're talking about Alzheimer's, frontotemporal dementia, Lewy body disease, PSP, corticobasal syndrome. You just go right down the list. These are network insufficiencies. You have these remarkable networks, these subnetworks that function in your brain, and they have been selected over evolution to be very good with performance at the expense of durability. So they break down. You're literally, it's like having a Maserati that you're driving at 220 miles an hour all the time. They break down over time. And so we have to continue to focus them and tune them and make sure that you're not failing in some of these different areas. When you have this insufficiency, you're just not able to keep up, and you've gone into that protection mode. Then over the long haul, of course, you are downsizing. You're going from your beginning of 500 trillion synapses, and you're now downsizing those synapses. And so you now ultimately, when you get to the point where you can't do normal everyday activities, you now have a real problem. You now have a neurodegenerative condition.
So let's talk about, there was a term in your first book, I believe the 2017 book, and I think it was called cognoscopy. I think you were trying to take a side road off colonoscopy. And, I've heard the story so many times. Somebody will go see the neurologist and they'll just maybe check a B12 level and say, get your house in order and here's some resources. And I mean, I've heard that. So in a functional medicine point of view or a precision medicine point of view, the term cognoscopy was very unique, and it made sense to me as being someone who did integrated medicine, functional medicine. I was doing a lot of those things, so I go, I can do this. I can do these things because we look at it this way. Can you go down some of the basics of a cognoscopy assessment for neurocognition?
Yeah, it's a great point, and that's another area where we've learned a lot since that time, because of course the new blood tests have come out just in the last 2 years. I just actually got my own p-tau 217, GFAP, and NFL checked a couple of months ago. I mean, everybody now, just like you should know your blood pressure, you should know your lipid profile, you should also know your p-tau 217, because that tells you if you're in the early stages. It's very much like a hemoglobin A1C for the brain. So you're looking to see, are you on that?
That's a great way to say it. That's a great way to say it.
Hemoglobin A1C for the brain. It's telling you, are you on the wrong side? Are you on that side that is the protective side? Because part of that protective side is you phosphorylate your tau. So if you've got a high p-tau, it's telling you your brain is in that protection mode. It's not over there on the connection mode. And people find that often quite early, and we can do something about it. And we make a big difference and bring it down over time. And well, so the original idea of the cognoscopy was that, just as you said, it was everyone knows when you turn 50, you should get a colonoscopy. Well, by the time you turn 50, as you know, you may have already a lot of changes that are going to ultimately give you a diagnosis of Alzheimer's down the road. Because when you get it, it takes about 20 years or so. So people begin these changes in their 20s and 30s all the time. So we recommend anyone who's over 35 consider getting a cognoscopy. And it's 3 things. Number one, it's a very simple online cognitive assessment, which you can do in about 20 minutes. In fact, you can get a free one if you go to mycqtest.com, MYCQ test, so cognitive quotient, CQ, mycqtest.com. And you can see, where do I stand? And it's free. And you can see, okay. Then the second part of it is, if you are already having some symptoms, you should either have a brain MRI. And my fervent hope is that more and more people will be doing volumetrics and ASLs, which is arterial spin labeling, because that's the way to get early. We see these MRIs all the time where they just say, well, I don't see anything remarkable. That's not very helpful. We can do much, much better without spending any more money with looking at what we get from the MRIs. And then the third piece of it is a set of blood tests. And now when we originally formulated this, it was the set of tests that said why. What are the things that are driving this? But now there's two pieces to the blood tests. There's the why and there's the if. Is that, do you really have a concern? And if so, why? So I already mentioned the ones for if, is there a problem? It's the hemoglobin A1C of your brain. So that is the three tests: p-tau217, which is telling you if you're on that protection side; GFAP, which is glial fibrillary acidic protein, that's telling you, is there inflammation and attempted repair going on in your brain? And then the third one, NFL, neurofilament light, that's just telling you, is there ongoing neuronal damage? So three very complementary pieces of information that we all should have. And, get it every 5 years. You don't need to get it that often. Every 5 years is good enough. And you can see, okay, am I in the right path or am I on the wrong path? The fact of the matter is, when we started this, there was nothing for Alzheimer's. We started this work years ago, and they'd say, oh, you've got Alzheimer's, and sorry, there's nothing you can do. Or they'd say, oh, you might have pre-Alzheimer's, there's nothing to do about it, come back in a year. And they'd keep doing that until they say, sorry, it's Alzheimer's, we have nothing. It's truly barbaric. Now the reality is, if everybody gets on active prevention or early treatment, then this should be a rare problem. Just as heart disease should be more rare if people will simply do the right things and check their lipid status and get on the appropriate diet, exercise, sleep, all that sort of thing. You can do much, much better. As I started to mention, when you get Alzheimer's, you go through 4 stages. You have an asymptomatic stage, which often occurs in your 20s or 30s. Then you have an SCI stage, subjective cognitive impairment, which lasts on average 10 years. There's so much we can do. In these first 2 phases, virtually 100% of people do very well. The third phase, MCI, mild cognitive impairment, by definition, that means that now you're starting to do poorly on cognitive tests. With SCI, the definition of that means there's something that's not quite right. You're not remembering things the way you used to. You're not performing the way you used to. But when you're still able to score normally on cognitive tests. And then the fourth and final phase, of course, is dementia. And that's where, by definition, you're losing your activities of daily living. So my hope would be that everyone would get on those. Now, the other piece of the blood test, of course, is simply what are the risks? What are the things that are driving this problem? And the fact of the matter is that it goes back to what are the key players here. So if you take all those 36 and now about 45 players, they break down into 3 major groups and 3 minor groups. The 3 major groups are anything that reduces energetics. So sedentary lifestyle, sleep apnea, and mitochondrial dysfunction, any of those things, the poor vascular disease, anything that reduces the energetic support of your brain. The second one, anything that creates inflammation. So as I mentioned earlier, it can be a poor oral microbiome, some, P. gingivalis or T. denticola. It can be a chronic inflammatory sinus disease. It can be a tick bite. It can be leaky gut. It can be being exposed to an atmosphere, with fires and things like that. Anything that drives inflammation increases that. And of course, the inflammaging is a common one. And then the third group is toxicity. And the toxins come in 3 groups themselves, which are inorganics like air pollution and mercury, organics, things like toluene, benzene, microplastics, anesthetic agents, those things. And then the third group is the biotoxins, things like mycotoxins, trichothecenes, ochratoxin A, things like that. So we want to look at those. And then the 3 minor groups are any reduction in neurotransmitters, reduction in trophic support for your brain, things like estradiol, testosterone, vitamin D, things like that. And then stress. And I have to say, as a scientist, I never thought stress was going to turn out to be so important. But as we all now realize, you just can't deny it. It is part. And by the way, as you get that stress and you move it, that is part of switching over to that protective mode. Your cortisol's going up. You are shunting away from the sex steroids and into the stress steroids. You're handling infections and things like that. So those are the things we look at, and that's what the tests do. So the blood tests are going to look at your homocysteine. They're going to look at your hsCRP. They're going to look at your HOMA-IR. They're going to look at your mycotoxins, all the things that fit into those 6 groups I mentioned. The good news is when we get a report from that, then we have a really good idea. And actually, I've just got someone, later this evening, I'll be going over his report, so you can literally see what are the things that are either driving it, not driving it. And when you address those and optimize them, that is what has given the best results to date. And I should say we just finished a randomized controlled trial, as you know very well, 6 sites around the United States, absolutely fantastic people I work with. I'm really honored to have done that. Dr. Craig Tanio in Miami, Dr. Ann Hathaway, Dr. Kat Toops, Dr. Christine Burke, Dr. Nate Bergman, and Dr. David Haas. So really fantastic to work with those 6 and really outstanding. We compared the results using effect size. It was called Cohen's D. This is through a statistician that we work with, really fantastic, Dr. Stephen Ada. And what Stephen showed is that if you look at all the different randomized controlled trials that have been published, we had the best results of any of them. In fact, it was 90% better than the second best one that has been published. So we're very excited about that. We want to understand how we can do even better because in our trial, 90% of people improved, but not 100%. So 10% of people did not improve. And the 90% that did improve, some of them improved only a little, some of them improved a lot. So the question is, how do we get everybody to improve a lot? Of course, the easiest way is we get them to start earlier. In this trial, it was only MCI and early dementia, no SCIs, no pre-symptomatics. That's, as I said earlier, even easier. So we're learning a lot about what it takes to get best outcomes. And we've published a paper about a year ago on people who had sustained improvements, another thing that had not been published before, sustained improvements for, in some cases, over a decade. In fact, patient 0, I treated in April of 2012. So that's 14 years ago and counting. She's still doing really well. I treated her when she was 67. She was the first, did really well. She's now just turned 82. And she's recently walked from the Pacific Ocean to the Atlantic Ocean, 2,700 miles. Judy Benjamin. If you go, you can see her online, judywalks.org. She is amazing, and she's now going to go to England and walk from Land's End to London, which will be wonderful. So she's still doing well, and when she's a couple times early on, she came off the protocol, and within a week and a half to 2 weeks, she started having problems again. She went back on, she did better again. So it does make a difference. This is biochemistry. If you've got the right energetic support, not too much inflammation, you've gotten after what's causing the inflammation, and not too much toxicity, your brain does very well.
Let me ask you. I'd like to go over some of the basics because that assessment I'd like to get into later, like the cost and what it does. But the basics. So controlling blood sugar, is that one of the number one things to do? And then comment on that versus you have to go into a ketogenic diet to have progress, or can you do it just by, let's say you had a low Homer score, or you had an A1C and a fasting insulin. I do fasting insulins all the time, and I try and keep everybody below 5.
Yeah,
that's
great.
my kind of. So, but can you speak about the diet first, the basic preventive diet and treatment?
And let me put it in perspective here. When we treat people, it's pretty straightforward. It's 7 basics and 2 specifics. 7 basics are, and we'll come back to the diet, you just mentioned that: diet, exercise, sleep, stress, brain training, detox, some targeted supplements. If you're low in vitamin D, if you're low in omega-3s, you're not going to do as well. And please remember, when we first set this up back in 2011 was when we were trying to do the trial. As I say, I saw the first patient then in 2012. It was hopeless. There was nothing to be done. Everybody, in fact, they would even have on websites, there is nothing that will delay, prevent, or reverse cognitive decline of Alzheimer's. Well, now we know that's wrong. There's a lot that will, but you've got to get it right. It's tricky. In fact, in our trial, 4 out of the 6 sites had fantastic results. 2 of them did not. They didn't help people. And in one case, it turned out it was because the person, it was handed off to a person who simply hadn't been trained in this. So, it is a little like surgery. There are really good people at it, and there are people who are not as experienced and don't do as well. So, okay, let's come back to the diet that you mentioned. And in fact, let me just quickly mention then the specifics, and that's infections and toxins. So you got to look for them. There are dozens of infections that can contribute to brain inflammation, and you've got to figure that out and address it. Okay, so as you said, the diet. So the goal is, and this is as my wife taught me, who is a functional medicine doctor, taught me years ago, it's really about having metabolic flexibility. So if you're going to have optimal support for your brain, you can't walk around with insulin resistance. So as you know very well, there are two things that our brains burn for energy. They burn glucose, they burn ketones. Now the problem is, as we all get to typically over 40, we lose both of those. So we become insulin resistant. So we're now not very good at burning glucose because we are resistant. Our insulins may shoot up to 10 or 12 or 15. We've seen them over 30 before. And then the second thing is, because the insulin is high now, and you literally you can see this at the molecular level, the IRS, which is the signaling piece that interacts with the insulin receptor, the IRS can become phosphorylated on its tyrosine residues or on its serine and threonine. On the tyrosine is when it's active and things are signaling through. When you become insulin resistant, you're now phosphorylating on the serine and threonine, and you're basically turning down the gain on this amplification. So the second piece of this is, as your insulin goes up, it prevents you from synthesizing the ketones that are needed for energy to be shipped from your liver up to your brain. So you've got the worst of both worlds. You've got a Prius that has neither type of fuel for it. So your brain is very much like a Prius. You got two things. So what we want to do is bring both of those back. So as we become insulin sensitive, we're bringing back the ability to utilize glucose. And then as we now become more insulin sensitive, we also bring back the ability to make and utilize ketones. So you brought up the issue, do you really need to be in ketosis? Well, it depends. If you are just looking for prevention, you are asymptomatic, your p-tau is normal, everything looks good, you don't necessarily have to get into ketosis, but you still should be metabolically flexible so that if you need the ketones, you can generate them. For those who are already symptomatic, we want to be able to go back and forth and have them use both. So we just tell them at the beginning, just use exogenous ketones because you need that fuel. How do we know that? We know that because Professor Stephen Kinane from Canada did an experiment years ago where he simply gave people with MCI exogenous ketones alone. And lo and behold, they definitely did better. And that was published several years ago. So we know that those ketones can help. And so, yes, we'd like for people to be able to go back. Now, where we have to be really careful, and again, this is why some doctors are better at this than others, and some practitioners better than others. If you have someone who's frail, who's got a low BMI, when they try to now get into ketosis by fasting, they often get worse, not better. So you have to kind of go, the people that are easier to do this are the ones that have a little extra fat, frankly. They can burn that fat, make the ketones. So when we see people who have, pre-diabetes and insulin resistance, they tend to be easier to treat. When we see the thin, frail ones, we have to be very careful. We want to be careful. They have trouble generating endogenous ketones. So that's when we just start with the exogenous ones, get them so that they can do better. They can burn their insulin and they can also have some ketones. They get that energy. Energy is absolutely critical. And I have to say, there was a group that did a very interesting study where they called it CMA, combined metabolic activators. They gave very high doses. And I don't think you're going to have this, you're going to be able to do this for years. But for the several months of their study, with these very high doses of things like Alcar, things where you could burn them for fuel, they did well. So clearly, energy is one of the important pieces for cognitive support.
You're talking about your keto flex, the 12 hours of avoiding fasting, and then 3 hours you don't eat before evening meals. Or bedtime. that concept?
Right. So actually, we worked this out with Julie G. And you know Julie.
Mhm.
Julie is an ApoE44 herself who had her own cognitive decline in her late 40s. And she, very smart lady, but she got down to where she was scoring in the mid 30s for her cognitive scores. And then she did doing the right thing. She came up to a 98th percentile. She's done absolutely great. She had some insulin resistance. She could not generate ketones initially. She found out ultimately by doing a plant-rich, mildly ketogenic diet, and doing that sort of approach, she was able, in her fasting at night, she typically does 14 to 16 hours. In general, if you're ApoE4 positive, which is 75 million Americans, most of whom don't know it, then you're going to be fine with 14 to 16 hours. If you're ApoE4 negative, and that's 3/4 of the population, then you want to do more like 12 to 14 hours, a little bit less. And again, if you are frail, be very cautious about this because it may make you worse. So you kind of got to follow along, see how you do, and see if you maybe need to add some ketones in there. So yes, you're right. The Keto Flex diet that we use, to me, it takes the best of the Mind diet and the Mediterranean diet. The problem with those is they stop short of generating the ketones that can be so helpful. So yes, again, if you're asymptomatic, you can certainly get away with it. But if you're trying to get optimal support for your brain, you want to be able to go back and forth, and you want to be able to have a plant-rich, mildly ketogenic diet. So it's now high in fiber, soluble and insoluble fiber, very good for keeping your glycemic load down, very good for keeping your lipids down, very good for detox, by the way. You're detoxing this with this high fiber diet. And we stay away from dairy because it's inflammatory for many people. We stay away from grains, even though I realize lots of other diets recommend grains. As Dr. Fasano has shown us over the years, many people who don't realize it actually can harm their gut with these grains. And so we tend to stay away from those. And of course, we want to stay away from simple carbs, as they can be a huge problem. So when you do that, and we see again and again, people do very, very well.
So some people, when they think of ketosis, they think of more animal food or meat.
Right. Yeah.
So can you talk about saturated fat for a minute, whether you think it's harmful or not harmful?
Right.
The great debate continues.
Yeah, no, it's a good point. And part of the problem and part of the reason there's such debates is because none of these things is right or wrong. It's what are you optimizing? Different people are different. As you know, people who have a lot of autoimmunity, things like lupus, sometimes will do best on a carnivorous diet. It happens to help those people. However, for people who have cognitive decline, so far there has not been a paper published to say, oh, look, a carnivorous diet is really helpful for people with cognitive decline. So far what's worked best is these plant-rich, mildly ketogenic diets to get the best outcomes. And as far as saturated fats, it's a great point you bring up. I go back to something that Mark Hyman taught us all years ago, that you don't want that triad. So if you have saturated fats and you have very little fiber, and you have simple carbs, that is what we call the Bermuda Triangle. That's a horrible combination of three things, and very damaging. So for people who are doing well and who are not eating carbs and having plenty of fiber, having some saturated fat, such as coconut oil or such as MCT oil, is not a big problem. But yes, especially if you've got vascular disease, okay, then you want to stay more on the even vegan. Some people do very well as vegans. You have to follow your vitamin D, follow the things that you would be normally getting from animal products. One of the good things about KetoFlex 12.3 is you can do it with or without animal products. So it's up to you. It gives you some flexibility and some openness. If you like it this way, you can do it this way. If you like it that way, you can do it that way. The bottom line is you have to get your brain to be sensitive to insulin. If you do a PET scan on someone who is coming down with cognitive decline, the signature of Alzheimer's is exactly that, a reduction in glucose utilization in the temporal and parietal regions of the brain. So it's literally saying, there you are insulin resistant, you are not taking up your glucose the way you should. And so, this is again intimately related to what is ongoing with Alzheimer's. So some people would say, well, Alzheimer's is just a metabolic disease. It's so-called type 3 diabetes. Well, that's part of it, but that's missing some of the inflammatory piece. It's missing all of the toxic piece. There's much more to it than just that.
So are you before we'll leave that in a second here, are you still are more concerned about fish now with microplastics and stuff like that? Or do you tell people to eat small, the smash,
Yeah.
you know,
You bring up yeah. So as you can see, things are evolving right in front of our eyes. So for years, we have said to people, yes, please eat wild caught, low mercury fish, which means not the ones large mouth, long lives, not tuna, not shark, not swordfish, things like that. And so just what you said, smash fish, salmon, mackerel, anchovies, sardines, and herring. Here's the problem. It's just what you mentioned. Microplastics are showing up in all of us. And of course, as we've all been told, on average, we now have about one credit card worth of microplastics in our brains sitting there. It's coming in all the time. We're getting exposed to these things, and we're going to have to find better and better ways. I think one thing that is very promising is for people, again, every several years, to go in for blood scrubbing. Either you could do this as ionosphoresis, you could do it as this new column coming out, MTX100, you could do it as plasmapheresis. These all are things that are removing microplastics from our blood. Now, to be fair, they're also in the organs, but there is a dynamic balance. So if you remove them from the blood, they're going to be starting to come out from the organs. You can wait a month or two and then remove some more. And slowly over time get these things back down. But you're absolutely right. It's an issue. Now, we know that there are greater concentrations of microplastics in the brain than in the liver or kidney. We know that it is associated with cognitive decline. We don't yet know if the microplastics are causing the cognitive decline or the cognitive decline is opening the door to the microplastics, or both. It may well be both. So we need more studies on these. But yes, it's a concern. And you may have seen that study that was quite surprising and interesting. They looked at people's carotid plaquing in their arteries, and they had some that had the same amount of plaques as those with microplastics in the plaques versus the ones that microplastics were not in the plaques. And the ones with the microplastics in the plaques did worse clinically. Even though the plaquing was not more, they did worse clinically. So it is a concern.
Let's talk about sleep. It's my weak, it's my Achilles heel is sleep. And it's not about I can't fall asleep. It's about I want to do this or I want to write at night or whatever. And so that's been there for years for me. And I just so any, I don't know, just explanations of why sleep is so important. Consolidate memory, the microglia, clean house. Tell us what happens during sleep.
Yeah, and again, this is a mode switch, just like connection to protection. You're going from wakefulness to sleep. And as you indicated, you need both. You're not going to accomplish a lot if you sleep 24 hours a day. On the other hand, you need that sleep for a number of reasons, and you mentioned some of them. So I should say I target, so I have a wearable. Everybody should have a wearable. They're going to help us with chronic illness, no question. Every morning, I check 4 parameters. When I wake up in the morning, I check, number 1, how much total sleep did I have? The goal is at least 7 hours. Number 2, how much REM sleep did I have? The goal is at least 90 minutes. Number 3, how much deep sleep did I have? The goal is at least 60 minutes. And yes, as you said, during that time is when the glymphatics do best and you do best with your detox. So especially for those people who have what we call type 3 Alzheimer's, which is where toxins are the main driver, they really need that deep sleep as part of the overall. They need the sauna, they need the glutathione, they need the detox, they need the fiber, but they also need that good deep sleep to start moving these things out. And then the 4th parameter is SpO2, which is the saturation of oxygen while you're sleeping. And you should not be dropping below 94%. You should be in that 94 to 99 range. And there was a very interesting paper just a few years ago where they simply took people and looked at their average SpO2 through the night. You may be up at, may go down to 89 and up to 99. They looked at the mean, and then they compared the mean, the average of their oxygen saturation while they were sleeping, to the size of various nuclei within their brain, including hippocampus. And the match was remarkably good. So if you had more oxygen saturation, you had bigger nuclei in your brain. You had less, you had low. So we always check everybody. In our trial that we just finished, everybody got checked to see if they had any sleep apnea, to see if they had any reductions in oxygen saturation. We want to make sure that people have a saturation which is going to support their brain. And by the way, this is also why we like things like EWOT, exercise with oxygen therapy. Even though it's only 20 minutes, during that time, you are pumping in more oxygen, better blood flow, and you are supporting that brain. And it does give you some long-term benefits. There's also, of course, work now published looking at HBOT, hyperbaric oxygen, also showing some improvement. So all of these things, again, understanding the underlying pathophysiology for each person, this is precision medicine, it's going to be personalized medicine, is so helpful for each person to get the best outcomes.
So let's go to another staple of, and that's exercise.
Yeah.
So, I mean, we all know it, but I just remember BDNF every time somebody, I'm trying to convince somebody, I'm saying you're increasing your BDNF,
Yeah.
and so exercise, and then the type of exercise. I think that's where, when I was in Ageless Brain, there was a difference than 10 years ago, that you got really into that.
We are, so everything is evolving. That's the good news. As I mentioned earlier, the blood tests, now you can actually look at your p-tau, which 10 years ago you couldn't do that. Except in your spinal fluid, but you couldn't do it in your blood. So now it's just, there are more and more things that we understand better and better. So with respect to exercise, there are multiple mechanisms. So there's a whole signaling pathway related to PGC1 alpha, which is triggered by this. The second thing is better blood flow and better oxygenation. As we all know, it's really helping you to pump that blood. Improvement in your vascular status overall. It's then also improving your insulin sensitivity. So it's the strength training that tends to do better with your insulin sensitivity, whereas the aerobic exercise and the HIIT tend to do better with your blood flow and your oxygenation. So all of those things can be helpful. But in addition, it is improving your sleep to have good exercise during the day, which is, of course, you don't want to be exercising at midnight, but you're exercising during the day. It gives you better sleep at night. And then guess what else? It gives you, it is an antidepressant. It's giving you a good feel. Everybody knows about how that post-exercise good feeling that you get. So that's another piece of it. And then, of course, you're often, with your exercising, you're interacting. So you're socializing with other people. If you're playing baseball, or if you're running around, or surfing, or biking, or pickleball, or tennis, whatever you like. These things are also social. So, what's happening, you're hitting multiple. So you're hitting 5 or 6 of the holes in the roof with just your exercising, which is really fantastic. And which is why, exercise has had such a good history for inhibiting cognitive decline, and just been so great. And again, doing this and as part of people turning around, I have to say, the most exciting thing for me to see is when people are having problems. They come in and they're like, get them on the right protocol, you get them doing all the right things, you're getting them detoxed, you're getting them to exercise, and boom, they turn around, they're like, a couple of months after they start, they say, wow, I'm so much better. And their scores show it. Again, we see it again and again. We see improvements in MRI. We see improvements in biomarkers. We see improvements in electrophysiology parameters. So this is not you're fooling yourself and you think you might be doing better, but it's just placebo effect. This is documented by multiple objective parameters. We also saw improvements in epigenetics in the paper, specifically things related to neuroplasticity. So, we're seeing these remarkable improvements. And again, not in everyone. We need to understand why that is. But many people that wouldn't have had hope before.
Let me ask you, because the reason I'm bringing this up is, people come in and they say, gosh, I don't have the money to all that testing, and so I say, are you exercising an hour every day? I might get
Yeah.
in the face a little bit. Are you
Yeah.
doing that? Are you staying away from sugar? The three or four basics. Are you getting sleep? And I raise my hand and I tell them I'm working on it myself.
Yeah.
But I was just curious. I was trying to think. I don't know if I've ever seen an aggressive exerciser that exercise an hour a day come in for cognitive decline. I mean, I just can't think of one. I'm sure there is one, but
It's a
vigorous
great point.
exercisers.
Great point, and it definitely is much less. In fact, years ago there was an interesting study where they were looking at what's the magnitude of regular exercise, and what they showed is when you've got, as you know, if you've got 0 copies of ApoE4, as I mentioned earlier, that's 3/4 of the population. Your lifetime risk is about 9% for dementia. Not zero, but it's not too high. This is for Alzheimer's related dementia, and which is the most common cause. If you've got a single copy, that's 75 million Americans, your risk is about 30% during your lifetime. If you've got 2 copies, your risk is about 90% during your lifetime. The magnitude of the effect of regular exercise is equal to 1 copy of ApoE4. So you could bring the 30 back down to the rest of us, the nines. And I checked myself a few years ago, so I'm an ApoE33, which is the most common one. It's kind of the vanilla that most of us have. I would love for the time to come when every single person in the country knew their status and was on active prevention so that they wouldn't have a problem. And we're seeing more and more people, by the way, who find out they're ApoE44. 7 million Americans are ApoE44. Great. Please don't worry about it. Get on active prevention. If you're over 35, and let's keep doing the right things. Two of the people we talked to recently, both ApoE44, both had symptoms, both have improved, and both of them brought their biomarkers, their p-tau 217 back to normal. Now, interestingly, one of them then was told by her doctor, oh, you need to go on a very high statin dose, dropped her LDL particle number way, way lower than it should be. And her p-tau shot up. Now, was it related to that? We don't know. But temporally, it was the obvious thing that happened at that time. So I hope that, again, we got to make sure the things are good for your heart as well as your brain. People will often say what's good for your heart is good for your brain. They don't always follow exactly. But there are many things that certainly overlap. And certainly part of that is blood flow and nice clean vessels and things like that. So there's no question that these things can be very, very helpful.
I want to go over two quick lifestyle things, and then I want to get
Yeah.
for you to answer what's the best home test to do. Like I do the mocha test in the office, but I mean, what can somebody, you mentioned it earlier, I want to have that where people can go online and do a really good cognitive test. Well, you can say that now, and then I'll get to the other things in a
Yeah.
minute.
So the best one is a free one available, and it's actually more sensitive than mocha. And that one is called MyCQ Test. Just go mycqtest.com. We did this along with the CNS Vital Signs, Alan Boyd, who runs CNS Vital Signs. So they have a very nice, very sensitive test that can be very helpful. And then it'll give you an idea, where do things stand, and should I be worrying about this? Because as you know, cognitive changes can sneak up on you. We're so often told, well, you're just getting a little older. Now, I'm just turning 74 in a couple of days. So, I'm going to be checking myself every few years and look to see where do I stand. But, people are saying, well, you're over 45, so you should expect to have problems with your brain. Well, I don't want to have problems with my brain, and you don't have to. We all know people who are 90 who are very, very sharp. And the point of that book that you mentioned, The Ageless Brain, which came out about a year ago, was to say to everybody, let's get things optimized and make sure that you don't have problems going forward. Because the reality is, this does not have to be. Now that we understand it better, and we understand the 36 holes, now about 45 holes, it should be a very uncommon problem.
I mean, the heartbreak, for me, I just had it happen to me today, actually, but I'll see a couple come in, and couples get used to living with each other with one person, you know, having a little, memory decline. And so they just live with it
Yeah.
and then all of a sudden they come in and they might think I'm a little overbearing, but I'm saying we got to do something now.
Let's go back over the years, how things have changed. It used to be that people, were overweight and ate a bunch of, steak and French fries all the time and just waited for the heart attack to happen. They're much more aware of that now. And we have to change the understanding so that everybody realizes you don't have to settle for cognitive decline. Even though doctors are still telling people often, oh, you're just getting a little older. And I've heard this all the time from people who literally were clearly developing Alzheimer's. And the doctor said, well, you're just getting a little older. That's to be expected. No, there's so much that can be done about it now.
Right.
Ultimately, I think we'll make people understand that you don't have to settle for this. Years ago, people thought smoking was fine. Yeah, you smoke, so what? Everybody smokes. Now we know that's not such a good idea. And we're understanding, although it's more complicated with cognitive decline, there are, just as you were saying, there are more things. It's about the sugar you're eating, and it's about the toxins you're exposed to, and it's about all these different things. But the good news is we can look at them, we can measure them, we can catch them early, and we can do a lot about it.
Tell me about the difference between, I call it, I'll go through these five things: exercise, diet, sleep, and then
Yeah.
I'll come to stress. And I'll say there's good stress. You enjoy doing something that's challenging for your brain when you're around people, versus overwhelming stress, like the patient I had today who has to make a decision about her husband.
Yeah.
This is a stalwart lady who takes care of herself, and I can see her withering almost in front of me.
Yeah. She's
So
got.
give me an idea of good stress, bad stress.
Yeah. So, as organisms, we were evolutionarily designed ultimately, or evolutionarily evolved so that we can handle brief periods of stress followed by rest. So, in other words, the stress tells you you're going to have to develop a little bit more. You're going to have to work a little. It's just like building muscle. It's just like building endurance. You get stress, you relieve it, and then you adapt. The thing that we were not meant to handle, which so many of us now have, is chronic ongoing stress. Just what you were describing. Here's this poor woman taking care of this guy, and it's chronic, unremitting stress. And as I've mentioned in the books, chronic unremitting stress is very damaging. And in fact, you can trace the molecular pathways in Alzheimer's disease. For example, the corticotropin releasing factor receptor. So this is the thing that's ultimately going to increase your cortisol. This is in your brain, and it's binding to a receptor, which actually is activating your phospho-tau and your amyloid. It's basically saying you're under assault. You better start pushing back. And so you can see that that is a critical part of this. Stress is indeed related. And this is why people do better when they handle small amounts of stress, and then it remits, and then they relax, and then they adapt to it. That's the key. And so this is why things like meditation and yoga have actually been so good and improving synaptic plasticity and improving cognition.
Any closing words? I want to get you out of here on your time frame. Is there any closing thoughts you'd like to say?
Yeah, thanks. And my feeling is everybody should understand that there is a huge burden of cognitive decline in the world. It doesn't have to be that way. We can do much better. And if everyone would get evaluated, if you're over 35, get on active prevention or earliest treatment if you start having symptoms. Don't assume that it's just a normal part of aging. And it is going to take different pieces. People often want a silver bullet. As we've said, it's about silver buckshot, not silver bullet. We got to get the different things, find out what's driving your risk, and address those things. And we really can make a world with much, much less burden of cognitive decline.
Well, I want to thank you very much for taking time out of your busy day and all the work you've done. I was kind of laughing, and when I look back, you were at the Buck Institute in 1998, and I thought I got there 10 years ago. And that was, 2016. I was going, wow, he was there way before then. So my best to all your work. Keep up the great work, and we'll keep the journey going. So I want to thank you, the audience, for listening to this edition of the Staying Healthy Today show. Until next time, stay and be well.